time if you don't give them the honest range of possibilities. They don't have time to put their plans in place. So what I will say when I'm training students is you actually want to make sure you give them the short-term worst-case scenario and tell them, let's put plans in place to make sure that if that happens, you've got everything taken care of, and if you get the miracle cure or you live 10 times or 100 times longer than we think, then great, you've gotten all your affairs in order and you can move on. But it's a difficult conversation to have. Physicians are increasingly busy, and these are also fairly time-intensive conversations as well. There's a decrease in primary care across the board, so it's not just geriatrics, it's family medicine, general internal medicine. There's increasingly fewer and fewer people going into it. It's a tough field. The reimbursement system for physicians is procedurally based, so cognitive services, as we call it, when you're sitting down and talking to patients, isn't paid in the same way that I don't want to pick on any specialist by naming procedures, but than doing procedures is. It's not a flashy specialty necessarily, and John's right, there's not enough exposure to geriatrics through the 4-year curriculum, and in fact, docs who talk about, or residents or med students who think about this, are oftentimes even discouraged from a lot of the specialists to go into this, based on the reimbursement and the workload in some ways.